Hi, good day. I'm Dr. Sadiq Kiwana, and today we will be speaking on the genetic tumor syndromes involving the central nervous system. All right, so we're looking at neurocutaneous disorders. It's formally called phakomatosis, and it's a group of multisystemic diseases that most prominently affect structures primarily derived from the ectoderm, such as the central nervous system, the skin, and the eyes. Most of them exhibit a autosomal dominant pattern of inheritance. There is a high rate of spontaneous mutations, and the syndrome should be kept in mind, especially in the pediatric population presenting with a tumor, and any other stigmata of these syndromes should be sought. So we would look at there are countless neurocutaneous disorders, but in this lecture we would look at neurofibromatosis 1 and 2, tuberous sclerosis, and Sturge-Weber syndrome. Although there are many other neurocutaneous disorders, some are mentioned here as well. They tend to be very rare, these. So we'll start off with neurofibromatosis type 1. It's also known as Recurrent-Hausen's disease, and it is the more common type. It's more common than neurofibromatosis type 2, representing more than 90% of the cases of neurofibromatosis. Its pattern is simple autosomal dominant form of inheritance with variable expressivity, but almost 100% penetrance after the age of 5 years. Now, the NF1 gene, which is located on chromosome 17, usually counts for the neurofibromin, and it's a negative regulator of the RAS oncogene. Now, the RAS is a tumor suppressor gene encoding for neurofibromin in the RAS pathway. So there is a so-called RASopathy involving the cell proliferation and growth. Now, the loss of neurofibromin as a NF1 mutation results in the elevation of the growth promoting signals, and the spontaneous mutation rate is usually high, reporting in about 30 to 50% of the cases representing new somatic mutations. Of note, prenatal diagnosis is possible by linkage analysis only if there are 2 or more affected family members. Approximately 70% of the NF1 gene mutations can be detected using protein truncation analysis. And in these patients with neurofibromatosis type 1, there is an increased incidence of other tumors seen in this population. There are other tumors such as pherocytomas, Wilms tumor, rhabdomyosarcomas, carcinoid tumors, as well as like leiomyoma and ganglioglioma. They're usually benign cutaneous and subcutaneous tumors arising from the peripheral nerves, and they can develop malignant peripheral nerve tumors. As we said before, it's a multisystemic disorder, and many organ systems can be involved, including the breast, the skin, the central nervous system, musculoskeletal system, the lungs, and the eyes and the orbit as well. So when we're looking at the diagnostic criteria for neurofibromatosis type 1, they're usually diagnosed if there are any 2 or more of the following of these characteristics, being more than or equal to 6 Corphioli spots, each of them being more than 5 millimeters in the greatest diameter in prepubertal individuals, or more than 15 millimeters in the greatest diameter in postpubertal patients. Also, the presence of more than or equal to 1 neurofibromas of any type, axillary or inguinal freckling. We also note optic gliomas, the presence of Lisch nodules, which are pigmented iris hematomas that appear as yellow-brown translucent elevations that tend to become more numerous with age. And we can also have skeletal involvement, such as sphenoid wing dysplasia or thinning of the long bones. And also, if there is a positive family history or a first-degree relative with neurofibromatosis type 1 by the above criteria. Leukocytes spots are hyperpigmented oval light brown skin macules or flat. They may be present at birth and they increase in number and size during the first decade of life. And they are present in more than 99% of the neurofibromatosis 1 cases and rarely occur on the face. So we want to look at what we call phases or focal areas of signal intensity. What these are that we're able to see on patients with NF1, we tend to see focal areas of signal intensity as seen here in this diagram in the basal ganglia, notably the globus pallidus bilaterally. Also able to appreciate the bilateral thalami as well as in the dentate nucleus of the cerebellum and in the brainstem. Now, these usually do not enhance the contrast and they do not cause any mass effect, which is a hallmark of these intensities in an MRI. They occur in up to 88% or almost 90% of patients with neurofibromatosis type 1, and it's the most common finding on a patient with NF1 on an MRI. 95% up to 95% of them are less than 1.5 centimeters, and they are really unsure of the pathological basis behind these signals that we see. Although it is thought that it is due to vacuolar myelopathy, where there are large fluid-filled vacuoles within or in the myelin sheath, right? Usually, this we tend to see this in the pediatric population within the first from age 3 to 10, where they may be increasing in size and the number. If it is, we tend to see an increase in the size of them or the number of them, or well, mainly the size of them over the age of 10, we should consider another differential diagnosis, some form of neoplasm. And usually after the second decade of life, there is a reduction in the size and the number of these signal intensities that we see. Usually, in terms of symptomatology, there is only a correlation with the bilateral thalami phases that is thought to cause some form of cognitive impairment, but that remains controversial. So, optic gliomers, they usually, we also wanted to, so we also noted that these are not usually in the pediatric population, but for this patient here, is a patient that had epilepsy and they wanted to look at the hippocampus. And we see here that this the abnormal or the signal within the bilateral thalami as well. If you have the normal hippocampus, there is a hypo-intense line that we see in the normal hippocampus that is lost in these patients with the neurofibromatosis type 1. Now, there is an article that was done showing where they call these UBOs or unidentified bright objects on brain MRI in children as a diagnostic criteria for neurofibromatosis type 1. And we see that the atomic locations of these are associated with the frequency, the basal ganglia being the most prevalent and the cerebellum being the least. Of note, the phases that are the uvules that are seen in the hippocampus and the brainstem, they are about the same frequency. So it's something that we should look for in when it is we do these MRIs or looking at these patients, the hippocampus. Optic gliomas, these are another part of the hallmark of these neurofibromatosis type 1, where they are observed in about 15 to 20% of these patients. The bilateral optic gliomas are almost always neurofibromatosis type 1. Right, we're able to see here on this MRI, the T2 and the T1 rated image with gadolinium, that on the left side here, there's a fusiform thickening of the left optic nerve, and it does show contrast enhancement. Now, they can show contrast enhancement, or they can be where, like in this image here, where it's not contrast enhancement. Yeah. So these optic gliomas develop in the first decade of life. The greatest risk is at the age of 6 years old. Visual impairment may be in about 33 to 50% of the children, and they may regress spontaneously. The majority of them are pilocytic astrocytomas, and they are rarely chiasmal as compared to optic gliomas in the absence of neurofibromatosis type 1. They are often multiple as well, and they tend to have a better prognosis when compared. They are usually non-progressive and should be followed up. These patients should be followed up with ophthalmology, with serial imaging, whether it be with MRI or CT. Of note, any form of surgical intervention does not alter the visual impairment, and therefore it is usually reserved for special cases, for example, patients with any large disfigurement tumors. So when we look at the management of neurofibromatosis type 1, neural tumors in patients with NF1 should be managed in the same manner as in the general population, where for focal resectable symptomatic lesions, they should be surgically removed. Any intracranial tumors may often be unresectable, and in these cases, chemotherapy and/or radiation therapy may be appropriate, with surgery reserved for cases with increasing or raised intracranial pressures. And malignant degeneration suspected, biopsy with or without internal decompression may be indicated. So next we look at neurofibromatosis type 2, which is also known as bilateral acoustic neurofibromatosis or Misme syndrome, in multiple inherited schwannomas, meningiomas, and ependymomas. Now, this is a historical misnomer. It's usually not associated with neurofibromas at all, and it's not related to neurofibromatosis type 1. In the early 20th century, it was considered a central variant of neurofibromatosis, where neurofibromatosis 1, where NF1 were more thought to be in the peripheral, in periphery, sorry. And it's usually characterized, the NF2, by the presence of intracranial schwannomas. Now, we look at the difference between schwannomas and neurofibromas, where these tumors differ histologically. A schwannoma usually arises from the Schwann cells, which produce myelin, in contrast to the neurofibromas, which consist of neurites, being axons, dendrites of immature developing neurons, Schwann cells, and fibroblasts within a collagenous or myxoid matrix. In contrast to schwannomas, which displace the axons, neurofibromas are unencapsulated and involve the nerve of origin. Now, neurofibromas may occur as solitary lesions or may be multiple as part of NF1, in the setting of which there is a potential for malignant transformation. Now, both these tumors, the schwannomas and the neurofibromas, have Anthony A, which are compact, and Anthony B, loose fibers, but the neurofibromas tend to have more Anthony B fibers. Usually, a patient under the age of 30 years old with a vestibular schwannoma is at increased risk of having neurofibromatosis type 2. So, neurofibromatosis type 2 usually occurs in approximately 1 in 25,000 to 1 in 40,000 patients or persons population. NF2 is considered an adult onset disease, and the average age of onset is 18 to 24 years old. By the age of 30, almost all affected patients will have bilateral vestibular schwannomas. Again, we observe an autosomal dominant pattern of inheritance, and it's thought to be as a result of mutation on chromosome 22, which results in the inactivation of schwannomin, a tumor suppression peptide. As we said, it's an autosomal dominant disorder characterized by bilateral vestibular schwannomas with other neoplastic and dysplastic lesions that primarily affect the nervous system. So multiple meningiomas are the second hallmark, occurring in about 50% of the patients, and there are two phenotypes. The Wishart phenotype, which is usually severe, there's an early onset, rare tumors and a high tumor burden, compared to the Gardner phenotype, which is usually mild. There's a later presentation, and the vestibular schwannomas are the only tumors, and we observe a slower deterioration of hearing when compared to the Wishart phenotype. Okay, so neurofibromatosis 2 is diagnosed in a proband that meets consensus diagnostic criteria, or only if one criteria is met in the presence of heterozygous pathogenic variant of the neurofibromatosis 2 gene. So essentially, we have they can be diagnosed if there's bilateral vestibular schwannomas on imaging, be it MRI or CT, or if there's a first degree relative or parent or offspring with the NF2 and a unilateral vestibular schwannoma, or if they have any two of the following, being angioma, schwannoma, glioma, or posterior subcapsular opacity. They can also be diagnosed if there is a unilateral vestibular schwannoma and any two of the following lesions, or if there are multiple meningiomas and the presence of a unilateral vestibular schwannoma or any two of the following, being ependymoma, schwannoma, or posterior subcapsular opacities. In terms of the clinical features, patients tend to present with seizures or other focal deficits. They may have skin nodules or dermal neurofibromas, coprolate spots, which tend to be less common than in neurofibromatosis type 1. The presence of multiple intradural spinal tumors are common, including intramedullary and extramedullary tumors, the presence of retinal hematomas, and the antigenic nerve growth factor, which is usually increased, which does not occur in neurofibromatosis type 1. Schwannomas are associated with neurofibromatosis type 2 WHO grade 1 tumors of neoplastic Schwann cells that occur at an early age, usually second decade of life, and sporadic or non-neurofibromatosis 2 type associated schwannomas, which tend to occur in the fifth decade of life. Although cutaneous neurofibromas have been reported cases of neurofibromatosis 2, many of these turn out to be schwannomas on histological analysis. In terms of management, so for bilateral vestibular schwannomas, the best chance we have of preserving the hearing is best when the tumor is small. So one should really attempt to remove the smaller tumor, and if the hair is serviceable in that surgery, then we should consider removing the next tumor on the contralateral side. If not, otherwise we follow the second tumor for as long as possible, and then perform a subtotal removal in an attempt to prevent total deafness. Now, stereotactic radiosurgery therapy may also be a treatment option, but most neurofibromatosis patients will become deaf at some point in their life. And of note, pregnancy may accelerate the growth of cranial nerve 8 tumors. And this is a table just giving the differences between neurofibromatosis type 1 and type 2. Of note, in type 1, we can see that the lesion nodules are common, not associated with type 2. Cataracts are present with type 2, but not associated with type 1. And the presence of skeletal abnormalities, such as scoliosis and the sphenoid wing dysplasia and stuff, that is limited to neurofibromatosis type 1. Okay then, so next we will look at tuberous sclerosis. So tuberous sclerosis, also known as Bonfils disease, where it was first described by this French doctor, is where the word tuber, which means root-shaped, and scleros, which means hard, he referred to the thick, firm, and pale gyri called tubers that can be formed pathologically in the brains of patients with tuberous sclerosis. Tuberculosis is usually an autosomal dominant syndrome caused by mutations of the TSC1 or the tuberin gene, as well as the TSC2 or the Harmatin gene on the chromosome 9 and 16, respectively. Now, one-third of the patients with tuberculosis it's inherited, and in two-thirds of the population, it's sporadic. So there's a more sporadic mode of inheritance of tuberculosis as opposed to inherited. The incidence is usually 1 in 6,000 to 10,000 live births. Now, there's a clinical triad of seizures, mental retardation, and sebaceous adenomas. Although this full clinical triad is seen in less than a third of the cases. These are sebaceous, so these facial adenomas are not really adenomas of the sebaceous gland, but small hematomas of the cutaneous nerve endings that are usually yellowish brown and glistening, and tend to rise in a butterfly or malar distribution, usually sparing the upper lip. So in the infant, the earliest finding is of ash leaf macules or hypomelanotic leaf-shaped macules that are seen with the wood slump. Infantile myoclonus may also occur, and in older children and adults, the myoclonus is often replaced by generalized tonic-clonic or partial complex seizures, which occurs in 70 to 80% of these patients. We mentioned the facial adenomas, which are not present but appear in more than 90% of these patients by the age of 4. Now, retinal in a position, so distinctive depigmented iris lesion may also occur. And this example picture on the left is where we see the leaf scene, and also the green patches, which is a product of the tuberculosis as well. So it is a neurocutaneous disorder characterized by hematomas of many organs, including the skin, the brain, the eyes, and the kidneys. In the brain, the hematomas may manifest as cortical tubers, glial nodules located subepidemally or in the deep white matter or giant cell astrocytomas. The associated findings may include pachygyria or microgyria. Now, the diagnosis of tuberculosis is usually made if there is the presence of two of the major criteria, or one major and two minor criteria, where we look at probable tuberculosis if there is just one major and one minor, and possible tuberculosis if there is just one major or two minor criteria. And these criteria here. Major criteria would involve more than or equal to 3 hypomelanotic macules, more than or equal to 3 angiofibromas, and more than or equal to 2 ungual fibromas. The sugary patch that we saw earlier, the multiple retinal hematomas, cortical dysplasias, including the tubers and the cerebral white matter radial migration, subependymal nodules, SEGA or subependymal giant cell astrocytoma, cardiac rhabdomyoma, and lymphangioliomyomatosis, and also the presence of more than or equal to 2 angiomyolipomas. Now, the minor criteria include the confected skin lesions, more than or equal to 4 pits in the dental enamel, and more than or equal to 2 intraoral fibromas, achromic retinal patch, and multiple renal or non-renal hematomas. So, subependymal nodules, so the tumors are benign hematomas that are almost always calcified and protrude into the ventricles. Now, the SEGA, or the subependymal giant cell astrocytoma that we mentioned before, is a transformation lesion, and it's almost always located at the foramen of Monro. It occurs in 5 to 15% of the patients with tuberculosis, and it is essentially only enhancing lesion in tuberous sclerosis. So in terms of imaging, plain skull x-rays may show calcified cerebral nodules. When we look at CT brain findings, their intracerebral calcifications are most common in 97%, and is a characteristic finding. There's also low density lesions that do not enhance, are seen in 61% of the patients, and probably represent a heterotopic tissue or defective myelination, and it's most common in the occipital lobe. Hydrocephalus may occur even without obstruction, and it's usually mild in the absence of tumor, and of course the subependymal calcified nodules. Now, in terms of MRI imaging, they tend to be subependymal tumors on high on 2 and low on T1, and only approximately 10% of these will enhance. So there's a low signal in the subependymal lesions, which may represent calcification, and there's also the presence of this radical band sign, which is an abnormal signal intensity extending in a radial manner, representing cells of varying degrees of neuronal and astrocytic differentiation, as well as difficult to classify cells. So this MRI here, we see it's a fair image of the brain, where we able to see these cortical tubers about the brain, and they tend to be more triangular in shape. Often triangular in shape. They are hyper intense on the T2 or the FLAIR imaging, and there is calcifications within these are usually less than the cortical tubers are usually less than for the subependymal tubers. And we also know the presence of the radial bands that we see here, the radical band signs, sorry, which are linear band-like projection, and they tend to extend from the ventricle all the way to the cortex, and they may terminate in a cortical tuber. They're actually better seen here, the radial linear bands on both images here, and we're able to notice a lot of the cortical tubers as well, scattered about the brain. Now, we also did say that just a few of them, about 10%, approximately 10%, will enhance with contrast. On the image left is a FLAIR, and on the right is a T1 related with gadolinium. And out of all these subependymal tubers that we see here, only 2 of them are actually contrast enhancing and not very brightly. They are also able to notice on MRI within these tubers central cystic change or central suppression or, on the FLAIR, and on the T1 they be CSF like low T1 signal intensity centrally. And this is one of the subependymal giant cell astrocytoma that we see that, as I say, almost all the time it protrudes into the ventricle. So the management of tuberous sclerosis, paraventricular tubers should be followed. Tubers grow minimally, but SIGA, or the subependymal giant cell astrocytoma progress, should be removed if they are symptomatic, and a transcallosal approach or ventriculoscopic removal are options. Infantile myoclonus may respond to steroids. Seizures are generally treated with anti-epileptic drugs, and surgery is really for intractable seizures. Surgery for intractable seizures may be considered when a particular lesion is identified as a seizure focus. Now, of note, with tuberous sclerosis, the goal of the treatment is better seizure control and not a cure or a cure of the seizure. Next, we will look at Sturge-Weber syndrome. So, Sturge-Weber syndrome is a neurocutaneous syndrome characterized by the presence of facial portwine pain in the territory of the division of the trigeminal nerve, the presence of leptomeningeal angiomatosis, and glaucoma. Now, this disease is really rare and sporadic. It's one of the only neurocutaneous disorders that is sporadic, wholly sporadic, associated with somatic mutations on the GNAQ and the GNA11 genes on chromosome 3. Now, it is also known as encephalotrigeminal angiomatosis, and the cardinal signs are localized cerebral cortical atrophy and calcifications, and the ipsilateral portwine facial nevus. And contralateral seizures may tend to be present in these patients. So when we're looking at the images here, this is the image of a patient of a patient with Sturge-Weber syndrome. And of note here, when we look at this image on the left, when we look at the cerebral hemispheres, we're able to appreciate a left-sided cerebral hemiatrophy. There is also, on the other two images, cortical and subcortical calcification seen in the left occipital lobe. And of note, the paranasal sinuses usually tend to have ipsilateral enlargement of the paranasal sinuses. And we're able to see this here on this image as well when you look at the frontal sinus on the left compared to on the right, where it's bigger. We also can look at the bones on the calvarium, where there is thickening on the affected side. So when we compare the left side of the skull here, the thickness on the right side, it's diffusely enlarged on the left. Right. Now we also have the soft tissue kernel on the left and the bony kernel. It is a really dense calcification seen within the brain here. On the right here, we look at these lesions that they're really linear in aspect, and they follow the contours of the cerebral cortex. And these are what we call the gyriform cortical calcifications, or the tram track sign. Right? You're able to see them here. Also, the better it's magnified, where we have the gyriform cortical calcifications. We're also able to appreciate here the ipsilateral enlargement of the paranasal sinus, the left frontal, and the thickening of the ipsilateral calcifical thickening noted. Okay, so on these images, on the left is T1 and on the right T1 with gadolinium. And we're able to really see the leptomeningeal enhancement with the one with the image with gadolinium. It's usually abnormal small blood vessels or capillaries within the leptomeninges. And the leakage of the gadolinium is thought to be because of a deficient blood-brain barrier. This is one of the gross picture of the leptomeningeal enhancement, the leptomeningeal abnormalities of the small blood vessels. So in terms of treatment for Sturge-Weber syndrome, treatment is usually supportive, where we use anticonvulsants for seizures. Lobectomy or hemispherectomy may be needed for refractory seizures. In terms of radiation therapy, complications are common and benefits are lacking, so it's not really indicated. Laser surgery for cutaneous nevus is usually disappointed. Better results have been reported from masking the nevus with a skin color tattoo. And that brings me to the end of presentation. These are my references. Thank you.